Go. Okay, so good afternoon, everyone, and thanks for coming for this grand round, for which I'll be presenting on managing the acute care frontline in a COVID-19 era. So this is going to be a practical case-based guide for doctors and all clinicians, actually. It's obviously very timely given everything that's going around in the world. But particularly, I wanted this presentation to be very practical for the junior doctors that we are on the wards, but I suspect people from all kinds of ranks, even senior clinicians, are going to have some benefit. Now, I think it's important to say that I'm not a full COVID specialist, but then again, that's why we have a group of specialists in all different areas to give us advice. And as you can see, we've got the Chief of Medicine, Simon Merritt, joining in for this. We've got the respiratory consultants, Dr. Christofferson and Dr. Kankam, and we also have got the palliative care and many other specialists. And I think that's an important thing to remember is that COVID isn't purely a respiratory problem. It is a multi-specialty issue, and we actually need everyone on board to get on top of this. So saying that, this is my idea of what I would hopefully like to achieve with this presentation. I'd like to provide the junior doctors with a practical case-based approach to dealing with COVID on the front line. I want to increase your awareness about the various documents, pathways, protocols, about how to treat and manage these patients even to the end of life, about the research trials that are also there for recruitment. I also want to improve your understanding of different concepts like TAP, red and green zone directions, and de-escalation. It's going to be a long, I think, quite heavy discussion session, but we're going to try to leave as much time as we can for Q&A so you can ask questions that are relevant to you. Okay. Now remember, everything that's on here will be somewhere referenced in the COVID-19 webpage on the internet, which I'm showing to you right now. So a lot of them will be found on the medical documentation, but there are many links, and I do recommend you thoroughly look at those documents when you need to, and possibly before you need to even. Now, it's important to know that some of these documents are updated regularly, so you have to be careful you're not looking at outdated document. And I've listed here some of the main websites on the internet, including the medical documents section, as well as the training directory and videos about CPAP, which Dr. Christofferson has kindly created. But there are many more on the website, and the key is to check on them regularly, make sure you're not looking at the outdated document. Now, we're going to start with cases, as I promised you. So I'm going to get Ketsia, who is one of our medical SHOs, to run through the next case with you. So Ketsia, if you don't mind.
Hi, good afternoon, everyone. I'm Kezia, one of the IMT trainees. So for today, the first case is you are the one of medical SHOs on call taking reference. So you got a referral from A&E. So he's a 70-year-old gentleman coming. He's currently in A&E red zone. He got late admission at 10 p.m. and his swab results are not back yet. He presented with temperature 38 degree and he's from a nursing home. There is no non-COVID case at nursing home. And he got a long-standing urinary catheter for benign prostatic hypertrophy and mild cellulitis over left leg. There is no respiratory symptoms, no cough, no shortness of breath. His vitals, apart from the temperature, it's pretty stable. The temperature, chest X-ray is normal. So from the A&E, they're treating it like a TAP, actually according to Clarking. So next we are going to go to our questions. So the questions are, what do you do? At the moment, we are reviewing the patient in the A&E red zone. So what will you do as the next step? First option, treat as a TAP and recommend patient transfer to red ward, or transfer to AAU, or transfer to another green medical ward, Or what further information would you like to make this decision?
Thanks for that, Katsia. So as an audience, I'd like you to maybe reflect on this question for a few seconds. And if you need to go back to the case, this is it. You've got a 70-year-old gentleman, red zone, it's 10 p.m., you haven't got your swab result, small fever, normal chest x-ray, normal SATs. You know, it's a common dilemma about where is this patient going to go to next. So give yourself a few seconds. If you want, actually, it's totally anonymous. You can message on the text group and tell us what you think. We won't say any names. We just want to know, this is open for discussion, because this is the whole part of this presentation, is to familiarize yourself with how we might do things. It's sometimes not necessarily a right or wrong, but it's important that you understand how pathways work and certain concepts about COVID that you never had to deal with a year ago. So Katsia, let's say you are the A&E, or well, the medical SHO here. What's going through your head?
Actually, it's like a tricky thing. Always I used to encounter the same. So what I think is, since, the patient got a temperature, but there is no respiratory symptoms, and the X-ray is normal, so I would probably think of transferring to AAU, or I'll take the advice from the senior, either registrar or the consultant, or wait for the post-take water.
Well, that's a lot of different options you're giving me,
sorry.
Katya. Well, we've got a few messages on the group. So they've asked us about the patient's symptoms. There is certainly no cough, as I said, no breathlessness. He is got that Mount cellulitis on the left leg, and that's what he's complaining of. His urine dip is positive for nitrites and leukocytes, which it can be with a catheter. His blood test, he's got a white cell count of 15, no lymphopenia. CRP is about 50. Another question I have is, what is TAP? Great. So we've got that question, and some people are saying treat as TAP. So that's a very interesting concept here. I think we've got a hands up from one of the candidates. Ms. Alam, you want to say anything?
Reality accept করতে হবে আমি আমার পজিশন আমাকে চেঞ্জ করতে হয়েছে কারণ
Mr. Alam, did you say something? No worries. Let me put that on mute for a second. Okay. So this goes back to the whole concept of what is TAP. And I think that's one key thing that we want to go through, which is a TAP is a patient who is strongly believed to have a COVID-19 infection, despite a negative swab result. Now, Dr. Merritt's done some work on audits here, where we've noticed actually that some of what we're considering TAP may not necessarily be TAP. And why is that important? Because if you incorrectly consider someone as a TAP and they go into a red area, that does increase their risk of exposure. So I think we have to be careful. It's a double-edged sword. It is important to consider TAP in patients where it's the right indication. But you may have noticed that actually even our local audits show that sometimes we incorrectly diagnose someone with TAP. Simon, I don't know if you've got anything you want to add to that for the time being before I go on.
No, I've got stuff that I'd say at the end. It's fine. I agree with what you've written there.
So if you are dealing with a TAP, we have a form for TAPs, which is, I think, quite important for you to be aware. And I mean, while it's not set in stone that these are the only criteria that would designate as a TAP, these are sensible things, like a chest x-ray with signs compatible with COVID, even the swab is negative, paroxysmal new lymphopenia, a cough with a temperature of more than 37.8, a new onset lack of taste and smell, or whether there's something else perhaps that still makes you strongly suggest it. And so this is important because I think all too often we have someone with a temperature, but there's another source of infection like a urinary catheter or cellulitis, but we consider them a TAP in the red zone, and sometimes they're incorrectly diverted to that. I mean, sorry to put you on the spot, Simon, but would you consider the patient we just described as a TAP? Or, I mean, if you don't mind asking, what would you have considered here? Would you have needed more information?
Well, I mean, based on the information that you've given and assuming there's nothing else going on, then no, I would say that there isn't any evidence to suggest that they have COVID, and that I mean, the pathways are changing slightly, so but given what we have now, I would agree with what Dr. Christopherson said, treat the infection that you can see and move them to AMU, or AAU, sorry, is what I would say.
Thank you. So that's really helpful, because I think this definition of TAP and how you classify it is an important concept for you as junior doctors to get grips with. And sometimes you might have difficulty with it, and involving a senior is not a problem, but be objective about it and use the TAP form when you need to. So we've got a second case here that Katya is going to talk to us about.
So the second case is you're a medical SHO on call taking referrals. This is another referral from Red Zone as well. He's a 70-year-old gentleman who lives on his own with no additional support, no family nearby. His past medical histories are ischemic heart disease, mild asthma. He's now coming with cough, breathlessness. His vitals, temperature 37.5, pulse rate 100, blood pressure 110/70, respiratory rate 16, saturating 95% on air. He's COVID swab positive. So the questions are, how would you proceed? Here we got a few different options. Maybe you can choose as many as you like. The first option here is chest X-ray, or CTPA, or start antibiotics, or urgent IT review, or start on oxygen, or start on Clexane, Respecform, start remdesivir, start dexamethasone.
Well, I've specifically designed this question to give you a lot of options, not because you have to pick one that's right or many that's right, but it's to start you thinking. There are a lot of options, and the question is how you systematically work on them. So perhaps think a few seconds about maybe your top 3 initial actions. I'm not saying any of them are not doable, that you have to do them step by step, but what would be your top 3 choices from this list maybe? And if you want, you can text it on the group. But just think about this before we give you an answer, because I think this is very critical. The whole reason for these cases is to kind of jog your thinking pattern about how you're going to deal with this patient when it's you on the front line dealing with it in the red zone. So Katya, what's your thoughts? What would be maybe your top 3 if you had to take a pick?
I would do a chest X-ray. Then definitely I would discuss the Respecform. I will start on the Clexane as thromboprophylaxis. Starting in antibiotics. At the moment, patient is saturating 95% on air, so no.
That's
oxygen.
right. So yeah, he's got the temperature 37.5, but nothing much more than that. We haven't said his bloods yet, but he is COVID swab positive. Okay, so I think that's a reasonable approach, and we'll talk through some of these things later. But a CTPA at this stage, I don't see the need. I think the key thing we're trying to get you to do with this is to gather how severe is this COVID positive patient. Is it mild, moderate, severe? And that's important thing to try to pick up from this. Now, before I go on to that, though, I think it's important you understand local pathways, which I think hopefully Simon can help me with here. And there are different things to consider. One is perhaps how the pathway works for a patient coming through A&E and how we work with A&E who's under a lot of strain to get these patients seen quickly and then triage to the right zones. The second is when you're admitted to Conquest, how you then get admitted to the right medical ward. And then lastly, the respiratory care pathway, which is what happens if you have a COVID positive patient and how you make decisions about the level of escalation and what you treat them with. And I think it's important that you have a grip on all these separate pathways. Now, some of these are being changed over time, so I don't want you to necessarily look at them in fullness and follow them rigidly to the letter. So this was an initial pathway. We worked with A&E single clerking, which at the moment I would say is not in use. So Simon will kindly correct me probably about how things are going. And the second thing is about red and green pathways. So I might defer to your judgment here, Simon, if you want to say a few things about how that pathway is evolving at Conquest.
Thank you, Steve. I will do. Stop me if I start going off too far.
No problem.
If we start sort of with working with ED, and we have a number of our ED colleagues on the call, and I think it's important at times like this that we all work together as a seamless team, not us and them. That the endless questioning on either side when we refer, etc., and the batting back, I think that just adds angst into lives that are going to be fairly full of angst anyway as things get busier. So as activity picks up in the red area, there may be reallocation of ED beds and expansion, but that's something really for the emergency department. But we would expect that one of the on-call team on rotation will be present within the ED red area pretty much all the time. Obviously, if there are no patients to be seen, it's not necessary, but otherwise we would expect that presence. And that was something we did last time quite effectively. In terms of, and then from a post-taking point of view, an acute medicine consultant point of view, we need to prioritise the post-taking and senior review of these patients, A, because they can be very sick, but B, because there are, even if we expand into the rest of ED, there's still a finite number of beds, and we can't have people waiting for hours and hours for a decision to be made to admit them. In terms of acute respiratory care, I'm just going to share my screen, Steve, if that's okay.
Absolutely, go ahead.
So this pathway is available on already on in the medical documents COVID section. Clearly, the more I zoom out on it, the harder it's going to be to see. But I would say we're not going to go through every bit of it. But the key things about this are that we must consider what respiratory support somebody either needs or indeed could have during their admission for COVID. So that all really starts with a treatment escalation plan and a respect form. And I think we need to get away from thinking about respect forms like we used to consider a DNER form. They're not, I mean, a respect form does include that information, but it gives an opportunity for medical team and patient to discuss, and for patient or next of kin to be able to indicate preferences as to what they would like their care to focus on. At one end, it would be life preservation against almost anything else, and at the other end, it would be to prioritise symptom control. So there'll be people coming in who are very young, and I would expect that we would be doing a respect form on absolutely everybody, because that means that there might be a point where the patient's unable to express their preference, but we've already discussed it with them. And things can change. People can come in very sick and recover, and people can come in looking like we should give them full active management, but actually they deteriorate despite what we do. So that's the first thing. The second thing is to say that we must involve critical care at an early stage. So if someone is suitable and fit for critical care, and there's a woolly definition of that really, but they're looking at the patient's pre-morbid state, what could they do before they came into hospital, how many comorbidities have they got, and what sort of level of organ failure have they got now, and how retrievable are they. But if there is any doubt, then we must get critical care to come. It's better for them to come and say, actually, I don't think this patient would survive a critical care visit, than for us to not ask for it where it would be indicated. Third thing to say is that the respiratory consultants cross-site have been manning a 24/7 on-call CPAP rota since the first since the first spike in COVID infections, and we continue to do that. So Switchboard have our details. So anybody, according to this pathway, who is suitable for CPAP would receive it on a respiratory ward, so Jevington Ward in Eastbourne or Baird Ward in Hastings, and that you would need to discuss with the respiratory consultant on call in advance of starting. And we would want to know things like, what are their saturations, how much oxygen are they on, what's their respiratory rate, what's their frailty score. We would want to know things like comorbidities, etc. as well. And it's key that we pick the right people. So there will be some people who are fit for everything and need to go straight to ITU. Other people who will go to Baird Ward to receive CPAP treatment but with a view to being escalated to ITU if they fail. And there'll be other people who will be going to bed ward who will have CPAP as their ceiling of treatment. And then there will be a whole other group of patients in which it's deemed that their comorbidities or frailty would mean that they would not benefit from CPAP. And those patients we would give routine care to, and we would consider obviously palliative care. In here I've listed remdesivir and dexamethasone. And I said I'm not going to go through this pathway. The last thing I would say is that our treatment aim really with CPAP would be to improve oxygen saturations and to reduce respiratory rate. And I think it's the respiratory distress indication and improvement that is the key thing for us to focus on. Are there any queries or questions at all about that?
Simon, thanks for that. There's a couple of things. One, I think hopefully you've already kind of given the answer. So we got a medical SHO saying, what is the expectation for medical SHO registrar taking referrals from RED, which is a bit, I guess, non-specific, but they say sometimes there's massive variation in starting antibiotics, nebulizers, blood's been bagged, chest x-rays and ABGs. And I think part of the answer to that question is some of the answers to those questions are in the document about managing COVID pathways on the intranet. But I don't know if you have anything specific to say about that, Simon, particularly like.
I'm trying to look at the comment now. So, I mean, you'd give nebulizers if someone is wheezy or has bronchospasm. So I think it really depends at the time. We have taken the view that we would treat these patients with antibiotics because at this stage, we won't necessarily have a COVID swab back. And even if the COVID swab is back and the patient has COVID, doesn't mean that they don't have superadded infection. So we would treat with antibiotics. In terms of blood tests, I mean, they'll come back when they're back, but looking at full blood count, USANEs, CRP, LFTs, D-dimer, troponin are all useful. And where is the pathway kept? So if you go to the search bit of the intranet and type in COVID, it will then come up with a page and you can click on medical documents. Some of the documents are not in date at the moment, but other ones are up to date. So for example, the respiratory care pathway is up to date. And well, I'm going to have a good clear of it. So within the week, anything in there is up to date. Did you want me to talk about pathways, or should I do that at the end, Steve?
That's a good question. I'm looking at time. I might just do a little bit more of the case, and if you don't mind, Simon, then
Sure.
just in case we run out of time, just to get part of the clinical side out. So I'll just carry on the case for Kezia. But so this patient is moved to the red ward. And 24 hours later, you are called to review him, and his sats are 89% on air. His respiratory rate's 18, heart rate's 92, blood pressure 105/70. So I'm just giving an idea about what would you do now. It's a bit of a different situation to when he was much more stable back in A&E red zone. Is the urgent IT review now too late? Are we going for CPAP, end of life care, remdesivir or dexamethasone? It's a very broad-based question, and it's more to get you thinking based on what Simon has shown in your pathway already. The one thing I would suggest, though, Simon, on that pathway, and this is a question for, I guess, Teresa and Osai as well, is so if we are in this blue category where this patient's on the ward, would then medical SHO seeing this patient, say, at 8 p.m. at night, then have to start thinking, do I have to wait for a respiratory consultant to say I can start dexamethasone or remdesivir? How does that work from practice?
So the indication for dexamethasone is patients with serious COVID, and serious COVID is defined as people with COVID infection or almost certain COVID infection and requiring oxygen therapy. So anybody admitted, other than people end of life, should be started on dexamethasone. Remdesivir, the indications are pretty similar, although the evidence isn't as good, and we don't have an unlimited supply of remdesivir, and we pretty much do have of dexamethasone. So I think my personal feeling, I'll see what Teresa and also, I think my personal feeling is remdesivir is reserved for patients who have significant respiratory failure and ITU, but I'd be happy to see what my colleagues say.
Can I speak?
Yes, please, Teresa.
So I think with this patient and with all patients with asthma, even if they're COVID positive, you have to treat their underlying asthma, otherwise they will get sick because we're missing out their treatment. Same with COPD. Don't forget to give them their nebulizer if you think they can't use their inhaler. Give them the standard treatment, and make sure you give oxygen when their SATs obviously are below the reference range. And then, yeah, I think on Simon's pathway, you can see the indications for CPAP are SATs less than 94 on oxygen, and that is the point at which then you need to call the CPAP consultant, but you must start the standard treatment beforehand.
I think that's an important point we were talking about, Teresa, is that sometimes people, for some reason, leave the thinking to the respiratory team, where actually we have to actually take some of that action promptly, because like you said, it's about following guidelines and not losing time doing the right measures to treat these patients. Does that sound about right?
Exactly, yes, because we've got limited CPAP machines and oxygen therapy, so we want to make sure they're reserved for people who will need it, and not for people who haven't had the correct treatment right at the beginning for their underlying asthma and COPD. So we want everyone to remember that, treat the underlying problem as well as looking at the COVID.
That's great, thank you. So just to move on a little bit, and then I'm going to ask Simon about the pathways again, is so we called the patient's daughter who lives in Australia, and she's obviously heard about the various research trials going across the world, and she's asked, why can't my dad get a treatment? So the question is, can he? Well, what do you do really? And I don't know if Osai is on the call at the moment, but obviously my next slide is to highlight the fact that we do recruit to the recovery trial. Osai, are you there? Or let's see.
Yes, I'm here.
Would you like to say a few things about the trial? Go ahead.
So yes, she's eligible for any patient who is COVID positive, suspected COVID, and a hospitalized patient is eligible for randomization to this trial. So yes. And what happens is that once you randomize the patients, if they agree to have a transfusion-based therapy, then they are also randomized to receive convalescent plasma, which is concentrated antibodies, COVID antibodies, monoclonal antibodies, which are experimental antibodies that have been created from human cell lines. And then the standard azithromycin is still being evaluated. This week, we are also, aspirin is also being added to it. And this is called the first stage of randomization. And if patients deteriorate and need to go to ITU, then tocilizumab is also available to them. And all these therapies are available to all patients, regardless of age.
Osai, from a practical point, if that patient asks a medical SHO, what should they do next? Do they start the process or do they have to contact you?
They do not need to contact me. Every doctor in the NHS is encouraged to undergo the training to enroll people on the recovery trial. And I will send a link, which I've sent several times in the past, after this to Agnes to share with all junior doctors. It's about 20-30-minute training program. The trust will recognize you as a recruiter, and then you can do the recruitment.
That's great, thank you. Simon, now might be a good time for you to talk about the pathway before I go any further, I think. It's just so that I don't run out too much time for that, because that is very important.
Okay, splendid. I mean, I think we probably, both of us should aim to finish by 1:45, shouldn't we, I guess?
Yes.
So there's a couple of things to say. As everybody will know, and I'll base this just for Conquest wards rather than Eastbourne wards, at the moment, previously, we took a view that we would have no such thing as amber, that we would have green patients and we would have red patients. Things are changing a little now. And Steve, would you mind just taking that slide off, just because it's changed completely. Yeah. Sorry, thank you. Guidance has come out comparatively recently, suggesting that there's no such thing as a green patient coming into the emergency department or indeed to AAU, that everybody who attends hospital, whether even in the absence of any clinical suspicion or signs of COVID, until they have a negative test, should be considered to be amber and not green. And that changes things a little bit for us. And so that would mean that we would only have red and amber patients coming into hospital, really. And then from our acute assessment unit, which will be amber, people will have a result. So if it's positive, they'll end up going to the red areas, and if it's green, they'll end up going to the green areas. So that's a big change, and there'll be emails and pathways coming out a little bit later this week. To enable us to be able to do this, we need to be able to do our testing in-house. So we have a machine called the Perkins-Elmer machine, which we've had now for a few weeks, and we've been calibrated. When I say we, I've had nothing to do with it at all, but it has been being calibrated. And when that comes online, we'll be able to perform around about 500 COVID tests in-house ourselves. At the moment, we're performing about 30 to 35 in-house because of the machine we're using. We have very limited reagent, and everything else goes to Southampton. And on average, it's taking between 25 and 32 hours to get results back from Southampton. We will be testing between 8 a.m. and 8 p.m. on the new machine, which should come into line at the end of the week. And the results will take will take between 5 and 12 hours, depending on when the sample has been taken. From the point that the swab goes in the machine, it takes around about 5 hours to give us a result. But if you've just missed a run, then clearly you've got to wait for the end of that, or if it's taken overnight. The next stage of this, which I won't talk about too much because I haven't got dates, is within the next 4 to 6 weeks, or 6 to 8, that we'll be doing 24/7 testing with yet another piece of equipment, and that will enable us more easily to move patients into the right area. But the key thing to say is that from the end of this week, stroke beginning of next week, is that we will be considering patients amber as they come into hospital. You guys may say, well, what difference does that make? So the only real difference it makes at the moment is that the Public Health England advise that patients who come to hospital where we don't know their COVID status, or they've refused to have a COVID test, we should wear a visor or eye protection, as well as apron, gloves, and a surgical mask. So the key difference, I think, is that at the moment, we are not wearing a visor or not wearing eye protection, essentially. So that, and I have got an email mostly drafted already that details that, but we need to start doing that in our admission areas. And once we can test within the same day, then we won't have any amber patients in our in the rest of our wards. Someone's asked about reliability of the machine. I think it's a PCR test, so its reliability is the same as often quoted. So it's around 80%. So there'll still be some people who will look like they've got Barn or COVID, but will come back as negative, and we would treat those as TAPs. Steve, there was a little bit I want to talk about instance of infection locally and things, but I don't know whether now's a good time or whether you want me to do that in a minute.
I think you might as well get it done now, and I'll hopefully breeze through the rest, so don't worry.
Perfect. So I'm just going to try and share a, okay, maybe not in that case. So I'll have to look at the, I'll stop sharing actually. I'll just have to read it out. I can't share it. So as of the 4th of November, because the data is updated every 7 days, the incidence per 100,000 of COVID infections in Hastings was 31.3, and that's actually decreased. In Eastbourne, it is 101 per 100,000, and that's sort of been going up and down a little bit, but hovering around about the 100 mark. Asymptomatic infection. So there's nothing we can do to avoid, to find people who have asymptomatic infection other than testing rapidly at the front end. That doesn't completely prevent people from slipping through the net, and we've had instances on both sites of patients who have come in asymptomatic and been swab negative, and then have ended up day 6, day 7 developing a temperature or respiratory symptoms, and us finding that they have COVID. So that's all the more reason why us wearing masks all the time is key. I know it's a pain in the backside, and I know it's not that comfortable, even the surgical masks, if you're wearing them for hours and hours. But there is some protection for us, and obviously we're also protecting other people by wearing them. And we need to think about our services, our wards, our departments. And if we have points which have happened in this trust and others where, I don't know, 5 or 6 people are all sitting down to eat together where you don't wear a mask and not social distancing, and one person has COVID, then everybody else is going to be isolating. And that's for a small to medium-sized hospital such as our own, it will decimate a department. So we need to be really very careful. That I think was all I was going to say, actually, Steve. I'm just aware that people might have questions.
That's pretty good. Yeah, and we'll quickly go through the rest of this to try to get there, and hopefully we can answer as many questions as we can at the end. A lot of the next few slides I'm going to breeze through because these are all on the documents page, but it's essentially about presentation and the fact that you have to keep an open mind that it's a chameleon and it can come in many different forms, such as loss of sense and taste and smell. Assessment is important, as Simon said. The Rockwood Frailty Score is very important in the right age group, along with other major risk factors such as infections, comorbidities of heart, respiratory, immunocompromised states. So don't forget when you're seeing these patients to do an assessment and look at these frailty scores and risk factors and take those all into account when you're assessing how far we're going here. Blood tests, ABGs, mainly in the type 2 respiratory failures. And some of the tests are non-specific, and you can get this on the document, but I put them down here, which you can access as this will be a video recording for the future. Chest X-ray signs, you can have a normal chest X-ray that does not exclude COVID. These are full-blown cases where you can have peripheral changes as well. And we've talked a lot about the management, which has evolved over time with the recovery trial data in terms of dexamethasone, but same points as Simon has said about getting a respect form early and making these decisions early, and particularly early critical care involvement when the need is there is critical. I think, you know, we've spoken to our respiratory colleagues, and one thing that we always, you know, really want to catch on is that you don't wait for that respiratory referral to make the right adjustments. You don't want this patient to be in a heap when they get onto the red zones, and then the respiratory consultants having to work extra hard to get the right involvement of the right people. So think about these things early. Recovery trial, and the rest of this I'm going to breeze through. Now, we've got a review bundle, but I know Simon said this is being updated, so I'm not going to dwell on this one, but there is a review bundle for COVID. And this is just giving an idea about the stages of admission for a patient and what we would expect about timescale. I mean, we have to see these red zone patients promptly to get the flow right and to get the right diagnostics done. So we're going to go to another case, which is something that I think some people have noticed as a small dilemma. Manjala, I was just going to present this case for you.
Hi, so you are the FY1 covering the wards over the weekend, and the nurse has bleeped from one of the green wards and has said that a 55-year-old gentleman is being treated for cellulitis, and he is in one of the 6 bedded bays. He is obese and has obstructive sleep apnea and is usually on home CPAP overnight. The staff feel he's getting more breathless, and the patient believes it's because he hasn't had his usual overnight CPAP. He did bring his CPAP machine in with him when he was admitted. So do you get an ABG done, start the patient on CPAP immediately, get a respiratory opinion, or transfer the patient to a different ward?
So thanks for that, Manjala. Dr. Christopherson, I've made this question specifically for you as because I'm sure you've got the right answer for this. So I don't know if for the sake of time whether you might want to say what you would do probably in this setting, because this is a very, very important question for juniors to know when they're on.
Could you just go back to the last slide?
Absolutely.
So it looks like he's on CPAP in the community, but not in hospital. So as Dr. Merritt was saying, every patient now is considered to be amber. So we don't know if they've got asymptomatic COVID. So for that reason, we do not do CPAP unless it's on bed ward.
I think that's the short and simple answer to this is you have to make sure that you aren't putting the CPAP machine on the wrong ward because you risk an infection. And that's not a good idea.
There is a slight caveat is that the British Thoracic Society guidance is that most patients on CPAP for sleep apnea will not come to harm by not using it during their hospital admission. So the first advice is that generally speaking, we would say that the patient shouldn't be using their CPAP. If there's a medical reason as to why they have to use it, then they need to be in a red area, which currently is bed ward. Some of you may know that we have a home NIV service locally, so we have about 62 patients on NIV. and none of those would manage if they were admitted to hospital without it. So they would need to be in a red area. So you'd need to speak to the CPAP consultant out of hours, or the ward respiratory consultant in hours about those patients.
Thanks.
Could I just add, we've had quite a few issues with the CPAP recently, and patients and relatives complaining. I think if the junior doctors are approached by a relative complaining, they can always go to the hospital policy site, and infection control have authorised that, and they're trying to advertise it, I think, on the trust site, so that patients and relatives know that we're following the national and global guidelines, that we won't be doing aerosolizing procedures outside a respiratory ward.
Thanks, Teresa. Okay, I know we're a bit rushed for time, so I'm going to try to go through these last few cases quickly. So this is for medical SBRs. You get called over the weekend, and there's a very, very tight bed status, and they want to get a patient from the red zone to the green zone, or well, amber zone. So this is a 67-year-old lady who was treated as a TAP, but the COVID swab was negative. Some consolidation on the chest X-ray and CRP of 70. She was treated with IV antibiotics, and she has had no temperature for 72 hours. And they're asking the medical registrar, can this patient be moved? So I think we do have a few registrars on, and I'm very curious to know what you guys think, if anyone's able to text what, would you move this patient? I don't know, Katsia, I mean, I know you're not a registrar at this time, but what's your thoughts? What would be your thinking process?
I would check whether the patient is. I'll do a clinical review whether the patient's symptoms has improved or not.
I think it's important to know there is a de-escalation policy, and it's important we are objective and things about it. So that's also on the medical documentation about if the patient's been isolated for 14 days, aparaxial for more than 48 hours, clinical improvement. And that part of that says to repeat a COVID swab is negative, you can de-isolate. I don't know if Simon or Teresa or Osai want to say any more about that. Are you finding any issues with de-escalation at the current times?
Not really in the Hastings site, no. In Eastbourne we have, yes, but there's no point talking about that now. I mean, it's difficult to know because there wasn't very much information, but essentially to become a red patient, you need to have new respiratory symptoms, loss of sense of taste or smell, etc., etc. And this patient did have that. We have to think the most common cause of lobar pneumonia is not going to be COVID, certainly not with our very low community prevalence. But one has to be careful, and I think with the information you've given, I would suggest that this patient's considered to be COVID. Someone just asked a quick question about, can't she go home after being afebrile for 72 hours? Well, I mean, I would say that you don't have to be afebrile to go home with COVID. And the vast majority of COVID patients we should be trying to manage on an ambulatory setting, depending upon their oxygen saturations, who they've got at home, etc.
I know.
Teresa, you had a question too. Thanks, Simon.
No, I was just reiterating that not every patient with COVID needs to come in, and we should be following the CURB 65 scores for patients who, if their oxygen levels are good, we should be following our normal guidelines for pneumonia. If they don't need to be in hospital, then they should be at home.
Thank you. So I think this is my last case scenario, and hopefully we can have time for questions. And I put this specifically because this is very, very often one of the most vital bits that is sometimes forgotten. And I know our palliative care consultants are here too. So this 82-year-old gentleman who was COVID positive had with COPD, ischemic heart disease, and a frailty score of 7. He's getting more agitated, delirious. He's on an end-of-life care pathway. And the question is, what do you do? And this all comes down really to making sure that while we can treat some patients, there are a lot of people who are going to get worse, and they may not be fit for ITU. And it's important that you refer to the palliative care guidelines we have for patients with COVID-19. They are on the Trust website too. But I think David Barclay's on this and Frida's on this meeting. And, I really, really appreciate your comments about the palliative side of this. It's still here. No, I think David's moved.
Oh, it's David gone. I'm here. Hi there. Yeah, thank you for keeping this in. It wasn't really a reminder just to say we've got the COVID guideline. I think it's really essential that we've been involved probably in about a third of the deaths in in the hospital in some way or other, people deteriorate really quickly. So it's really imperative that you can get in quite quickly with symptom control, with assessment, seeing particular symptoms. And obviously we've got slide up here has got all the different symptoms and the different medications that you might want to think about depending on their clinical state, their EGFR, things like that. But I'd say don't wait to refer to us. We're happy to discuss anyone. We also started a 7-day service during April 2020 during the COVID, so there will be a palliative care CNS during the day at the weekends. There's on-call advice as well, but please follow this. And there's also a last days of life care plan, the purple document, that's specifically for COVID-19 patients. So it's slightly shorter. It is slightly difficult. One thing that we picked up and everyone will picked up is discussing with family members who cannot come into the hospital, might be self-isolating. Often you might be having to have conversations with people over the phone that you've never met before to talk about a deterioration. So it's just about supporting, each other in being able to do that. I don't know if Jane or David are on the call or anyone else wants to say anything from the palliative care team.
Thanks a lot for that, Frida. That's really helpful. I think it's an important part we mustn't miss towards this dignified and comfortable death in the difficult situations important here. Those are the cases, and I think the take-home message is here is the same as I said before. Familiarize yourself with the different pathways and documents so you know what to do at the right time. When you're faced with variation, you've got at least something to base your decisions on. When in doubt, ask the senior. A prompt senior review and the rapid ICU review when needed are key parts. And as a message of hope is we have to stick together. Don't forget to be kind to yourself and to others. And this too shall pass, I think. We know that we are changing and we are getting better at how we manage this pandemic as a group. We also know that hopefully the future is bright on the horizon. And I would say, don't forget that through all the long slog that you're doing, and good luck. And with that, I'm very grateful for you guys for coming to this presentation. I think we've got about 68 attendees here. So this is what we want. We want you guys to see this, to learn from it, to understand, how to treat your patients at the front line better with COVID. So with that, I think we've got at least another 8 minutes, hopefully, for Q&A. So, please fire away any questions you got on the text box, and we will try to answer them the best we can. So looking at it at the moment, Simon, have you got anything else you want to add before I try to answer some of these questions? Let's see.
All I would say is that we are going to be sending out regular email updates to the medical division. One went out about 2.5 weeks ago, maybe 3 weeks ago, with some documents attached, and one went out, I think, yesterday, also with some documents attached. The one yesterday was about well-being. And all I would say, although we've obviously been quite clinical in this and talking about treat this, treat that, treat as positive, etc., that our patients, so we're useless to our patients if we don't look after ourselves. So there are lots and lots of things that we can be doing and should be doing. Taking our leave, for example, is a key thing. In the first spike, a lot of people cancelled their leave. On the Conquest site, I don't think we actually asked anybody to cancel their leave at all, but a lot of people, including me, felt that they should. But I think this is going to go on for longer, and if we don't take our leave, we're going to end up exhausted. So I would suggest that we book our leave as per normal, take it as per normal, and clearly, if we have a crisis, we may need to say to some people, "Look, can we move your leave dates, etc." But we're certainly not doing that at the moment.
Fully agree. Thanks, Simon. A few questions that may slightly relate, but I'll try to answer them anyway. Is there any guidance around visiting at the end of life in the red zone? I.e. the number of people allowed around the bedside. Teresa, might you be able to answer that, or I'm not sure who's best to answer that.
I can answer, yes. So one thing what we've noticed is we do have to advise the family that they're coming into a red zone, and if they're working, they will be coming into an area where they could get COVID, and they'll have to self-isolate from work. And a lot of relatives just don't even think about that. And as soon as they realise it's going to affect their income, a lot of people don't want to actually visit relatives. And it really is important as doctors and nurses, we advise the family that, because there's no point in them regretting coming in and complaining they weren't told that information. You'd imagine they should know, but often they don't. We currently advise that one person of the family attends if they wish to, and they'll wear the PPE. The nurses help them wear the PPE and advise them what they'll have to put on and how to put it on. But we don't have big groups of patients' relatives arriving because it's hard to manage them, and obviously we have to make sure infection control measures are followed.
Thank you, Teresa. That's really helpful. Frida, you've got your hand up. Do you?
Yeah, I was just going to say there are, if people can't get in or people are deteriorating too quickly, there are other ways. We've got iPads, we've got support in trying to see your relative. I know that David and Jane are re-looking at the visiting policy, so I can't give you anything concrete as yet, but obviously that's been re-looked at and that'll come out. But where people are dying, we are, if you, as Teresa says, if you give people, if their relatives information, we are looking at letting one person come in if the patient's dying. Am I right in saying that, Jo? Well, actually, there is variability between different wards, but I guess even more reason sort of also for a policy, just so that we're all doing the same thing.
Thank you. That's really helpful. There's a question which is maybe the wrong form, but we'll try to answer it. Are there any indications yet whether junior doctor rotations are not going ahead in December like we had in April? I think the answer is no, isn't it, Simon? There is
all the rotations are happening as per normal.
Thank you. There's a question about any clear advice on the pregnant patient with suspected or positive COVID test, and I think I'll refer you there on the clinical information site of our COVID intranet. There is a guidance on COVID infection in pregnancy from Obs and Gynae. So I think there is resource for that, basically. Simon, you wanted to share your screen, is that right?
I do, but I got so many things open at the moment, I can't get it. So hold on, maybe I've just discovered something that I will be able to get it. Do you carry on? I'll share my screen so that people just look at the instance as and when I find it.
No problem. This question of if green wards are now amber, do we need to change routine visiting rules?
No. Well, green wards aren't amber. So all right now we're in a transition, and so this is why we haven't introduced this yet. So red and green exist as they have done for the last, I don't know, 4 months. But as and when we are using the Perkins-Elmer machine, we will then find that our admission units are amber. So that will be AAU at the Conquest, and it may well be a bay in another ward. We can talk about that offline. And then people will go from there to the red or the green areas, depending on whether they're positive or negative. If they are clearly positive at the beginning, as in they've got undoubted infection or we already have their swab result, they'll go straight to red. So the amber areas will be asymptomatic patients where we have no clinical suspicion of COVID, but in whom we have not got a COVID test result yet.
Thanks, Simon. A few other questions. One from a medical student. Are you planning to continue medical student placements? I don't know if Dr. Whitehead is online, but I think
we are.
Yes,
we are carrying on. We are carrying on with medical student placements. Absolutely.
Absolutely. One question. I've been asked to give advice about contact tracing for patients on the non-medical ward out of hours. Would we just refer them to track and trace? Yes, I think I suspect that would be the case. Sam, I don't know if you know the answer to that one. That's a bit of a unusual one. Would we give advice about contact tracing? Well, we would refer them to the track and trace, I suppose. Yeah.
I haven't really thought about that.
Yeah, that's an interesting one. Is SDEC now amber? We've got from one of our AAU consultants, I suspect. Is that the case, Simon?
Sorry, I was talking to myself, having muted.
So
right now, AAU and SDEC are green, but because we are transitioning and patients coming to SDEC would not have had a swab and may actually not have a swab at all, we would consider them to be amber, and therefore we would wear eye protection, whether that be a visor or goggles.
Okay.
So we're in a transition. I almost wish I hadn't talked about it, but given I had the opportunity now, and it's going to be coming out soon, I thought I should do. But right now, nothing has changed, but things will change towards the end of this week, beginning of next week. If everyone looks at the emails from me, they will be updated.
Thank you, Simon. I think it's one thing we know that the situation is fluid and dynamic, and we have to keep an eye on that. It is now 2 o'clock, and I think, you know, this has been really good. I think we've covered more than I was hoping we could. And I'm really grateful for all the specialists who've been able to dial in and give their specialist advice about this. This recording will be available in due course on the website, so you can refer to it if you're in doubt. But as I said, a lot of documentation will be on the intranet, and, you know, stick together, work together, know what you're doing, and hopefully we'll get through all this. So I wish you all the best, and thank you very much.